All right, I think that's our cue. All right, good evening, everybody. Welcome to this week's AMSSM National Fellows Lecture. I am Craig Pille. I'll be moderating tonight's presentation. Just a couple of housekeeping things as a reminder. This lecture series ideally serves just as an adjunct to your CAQ exam preparation. It's to be utilized as like a supplement to the academic learning that you guys are doing in your fellowship experience as well. Please mute your device's microphone for the duration of the lecture, and you can submit any questions or comments through the chat function, and I'll bring them up to Dr. Yost after his presentation is done. Today, we'll be hearing from Dr. Yost on a very high-yield discussion topic, sports dermatology and dermatologic conditions that come up very often in the training room and elsewhere. Dr. Yost is a personal mentor of mine and a member of the faculty at the University of Maryland's Department of Family Medicine and Orthopedic Surgery. He serves as a team physician for the University of Maryland College Park, where he offers care for all sports, but most commonly you'll see him on the sideline of football, wrestling, and the men's lacrosse team's games. And he's also the head team physician at the University of Maryland, Baltimore County, the McDonough School, and most recently the USA Lacrosse Men's Sixes national team. So without further ado, I'll turn it over to Dr. Yost for some very interesting discussion.
Thank you, Dr. Pille, and thank you for the nice introduction for having me here today. So today we're going to talk about sports dermatology in general, just talk about dermatology you'll see in the training room and what other things you may see and how to get the athletes to return to play and what criteria do we need, especially with wrestling, on that return to play schedule. So starting out, I do not have any disclosures. And then the objectives today are going to be the common dermatologic diseases of the athlete, understand the treatments of common infections of the athlete, understand the return to play, just like I said, for common different diseases that we see. So first thing we're talking about is epidemiology. The incidence of related skin infections is 8.5% and 20.9% of all sports-related conditions and injuries in high school and college, respectively. Skin infections among high school athletes are broken down in as follows as far as bacteria, herpetic viruses, and tinea fungi infections. More than half of skin infections affect the face, head, and neck. Herpes gladiatorium, as numerous authors have suggested and shown, estimated overall prevalence about 20% of sports-related infections. And among college athletes, the prevalence of skin infections have increased, and we are more seeing herpes more and more commonly in the athletes in the college population, up to about 47 to 50% nowadays. And we also see a lot of impetigo, as well as the fungi, and also other different diseases as well. The reported statistics from Minnesota State wrestling tournaments from 97 2006 showed incidence of skin infections of 2.5 to 3.7%. And the National Collegiate Athletic Association Wrestling Injury Database, which is now through 2004, but has also progressed, has shown 0.98% of 1,000 athlete exposures, with one exposure being equivalent as one practice or game having an infection. So it's definitely something we have to think about, something we will see. 20 years ago, it was not really seen in high school athletes as far as herpes, and skin infections are not seen as commonly, but something that's on the rise and prevalent. And working with college athletes, it's very common. They'll come in already having a herpetic outbreak while in high school. So something that you are seeing in high schools as well as in colleges. So this is a very generic skin form. If you do wrestling tournaments and work with wrestlers, you'll see this skin form. This is one that's for the high schools. So it's really about very generic, has the body, and you can state what, infection they have, what treatment they've had, and when they can return to athlete, return to play. In the bottom here, I know it's kind of small print, but it'll kind of tell you exactly what it is, with its herpes, when they can go back and things like that. So it can be a guide for you if you don't know when to allow them to return to play. It can be a guide that you can use to look at that and use that to say, okay, they've been on this, like say it's herpes Beltrex for so many days, they can go back, so and so. The college form is very similar as well. Really, the only difference between the two is you grow hair when you're in college. So the guy has a hair on him, but besides that, it's about the same. And then the criteria again is on the bottom here, where it'll show different things of when they can return to play. So we're going to start with fungal infections. So we're going to go over tinea mainly, so capitis, corporis, pedis, versicolor, and barbae. And we'll break those down and go return to play. So for tinea capitis, usually presents with a patchy, scaly area and also can have alopecia. So they'll have a spot on their head that may have no hair, but usually it's like again patchy and scaly. And the treatment for this is a lot harder than it would be for tinea corporis, which we'll get into, because of the hair follicles and the penetrance. The over the the ointments and things like that do not penetrate very well, so they usually need oral antifungal treatments for at least 8 weeks. So the return to play for this is actually a more stringent return to play because of this, because they cannot cover it as well. So it is a 14-day return to play protocol for this. However, you'll need to do oral for this and not just the ointments. The ketoconazole shampoo is often used with this as well in the first 2 weeks, as it's been shown to decrease the transmissions. A lot of the athletes, what we'll do is we'll do the oral pills plus the ketoconazole shampoo to minimize the transmissions among the athletes. I threw in Tinea barbae here as well, as it is very similar to Tinea capitis, but now with wrestlers and able to grow beards and wrestle with beards nowadays than before, we will see this as well. So they do have this. It is treated just like Tinea capitis and does need 14 days of oral antifungal treatment. Again, not an ointment you can use for this. It has to be the oral, and they cannot wrestle because they cannot be covered. Technically, could they shave? And the tinea corporis could be outside the beard, and they can use the ointment at that time, which is possible. As long as they can cover it, they can get back sooner. So we're talking about the tinea corporis. So with tinea corporis, that's going to be a part of your body, right? So with the barbae is the beard, and capitis is the head, corporis is the body. So you're going to have this scaly erythematous ring-shaped raised border with a central clearing, and then you can also have a eczema overlie that as well. Sometimes you're going to treat this with the topical antifungals with the ointments. You're going to do that for at least 72 hours. And then return to play for NCAA is actually immediate. So if they have it on one of the skin checks, as long as it can be covered and they can wrestle with it covered, you can go back right away. If it cannot be covered, it falls into the high school regulations of needing 72 hours of treatment. So high school is 72 hours of treatment. You can even if you can cover it, need 72 hours of treatment before they can return to play. So they'll need a skin form saying they've been medication for this for at least 3 days before they can return to play in their meet or dual tournament. And then for college, they can go back right away. If there is eczema overlying it, sometimes you can use a hydrocortisone or a topical steroid to decrease the eczema over that area. So it's something to keep in mind that if you do see it, or say the ringworm is now gone, you may use some hydrocortisone cream over that if it's more eczema at that time. So tinea pedis, this is another one that you'll see very commonly. Incidence about this is about 70% in male athletes and 43% in female athletes compared to the age match control group, and then 20% in men and 0% in women. In athletes, usually it's going to be the maceration, right? A lot of the athletes will be showering after practice, after games. So in the showers, trying to use slides or shoes in the shower, but most of them or some will not. So it increases the risk for that as well. Also increases the risk for secondary infections due to breakdown of the skin, allows for cellulitis to be apparent as well. So we've got to keep that in mind. No restriction on return to play, so it's not something you need to hold them out for, but if they do get secondary infections, it may result in something that causes them to miss time. And you do want to treat with topical antifungals. However, in severe cases of things that more is not responding to treatment with the topical antifungals, you can do oral treatment as well to help get rid of the tinea pedis there. Again, the biggest thing you got to worry about here was the cellulitis with multiple athletes I'll see who have tinea pedis, wind up getting secondary cellulitis, and whether it be MRSA or things like that too, that holds them out longer. So make sure that they're taking care of their feet and keeping them dry, especially in the warmer months where it's usually sweat. Another one we're going to talk about is tinea versicolor. This is the hypopigmentation, patches of the skin. We used to see this more probably 15, 20 years ago, in people who used to go to tanning salons, right? When people love to get their tan on and try to be tanned and for prom or for college, whatever it's what they want to do. They come back and they have all these white spots on their chest and their back. And what we found out is that, that Malassezia furfur was the cause of it. And there's no restriction on return to play. And it's really easy to treat. So that'll be with selenium sulfide. do 2.5% shampoo. And you want to do that for 15 minutes a day for 3 consecutive days. And then observation after that, you know, the fungus itself is very easy to treat, but it is, again, hard for that melanin to come back, the pigment to come back. So even though it will have the hypopigmentation remain for a little while, it can take weeks to months for that to fully come back. But again, that fungi will usually be dead pretty quickly. So kind of going over the antifungal medications, we talked about what to give and what to use. So for antifungal medications for oral, usually it's fluconazole, Grisio, Fulvin, itraconazole, or terbinafine. Grisio used to be the first line of treatment. However, due to safety, it's now been not used as much due to the increase in LFTs. So fluconazole and terbinafine are more used more commonly now because it has less LFT risk, but does still have LFT risk or liver function test risk. And it also has the same effectiveness as griseofulvin. So again, it's been using more of the fluconazole, which is weekly, or the terbinafine, which is daily. If you want to do topical, clotrimazole, ketoconazole, or terbinafine. Clotrimazole or ketoconazole are probably the two main that have been used, but terbinafine is another one you can use, especially for tinea pedis. They make sprays for those as well they can use for there. So return to play. So again, kind of rehashing that, right? So you see a person in the training room. When can they go back? Tinea capitis and barbae. It's going to need 14 days of oral treatment. Corporus in college, go back right away as long as you can cover it. In high school, need to be three days of treatment and then also be covered. And then pedis and versicolor do not need any restriction and can go back right away. So now we're going to get into viral infections. We're going to talk about each section, what each one looks like, and then do the return to play and treatment. So again, with wrestling, you'll see a lot of herpes gladiatorium. We'll also see different things like herpetic labialis, herpetic whitlow. I've also seen herpes zoster and molluscum contagiosum. These are all different viral infections that we see, and we want to know what they look like because some can kind of mimic other things as well, so you want to make sure you're treating the right thing. So herpes gladiatorium, aka mat herpes or wrestling herpes, due to that clustered vesicle and erythematous border. So this is usually seen on the face. And with these athletes, for the most, if they've had it before, they know when they're going to get it again. So usually they'll have like a tingling sensation or pain in that area before they have an outbreak. And usually it's in the same area each time they get it. It's most commonly, again, seen in the face. We also see it in an antecubital area. Also can see it in their arms and their legs. So it can really be anywhere, but most commonly it probably is seen in the face. It's caused by HSV1. And you can diagnose it with a PCR, like a zinc smear. However, it's very costly, and the titers take about 24 to 48 hours, and the yield is actually very low, actually diagnosing about 7 to 25% of the time. So honestly, how I usually diagnose is more clinical based and then treating them as well. So labialis is also known as cold sores. So for this one, it's usually around the lips and the mouth. Abreva is a great over-the-counter medication that can be used to help shorten the course if used right away. And one thing that I found interesting is that for the people out west and people doing ski medicine, it's actually more common in skiers than any other sport. The reason for that is stress and ultraviolet radiation can cause increased risk for exposure and outbreaks. So having a common student athlete who's doing skiing in the snow, using the radiation and the reflection off the snow, actually increases the risk of herpes labialis secondary to high altitude in the outdoor sport. The study authors have shown before that they recommend using sunscreen with SPF of at least 30 to help limit the outbreak of herpes labialis. So something to keep in mind that if you do have skiers who have a history of herpes or herpetic labialis, to use sunscreen around the lips with SPF of at least 30. Next one we're talking about is herpetic whitlow. Usually it's on the fingers, again, caused by HSV1. It can also be caused by HSV2, but that's a lot less common. You're going to have swelling, redness, tenderness, as well as can have a fever and systemic signs of swollen lymph nodes. Most times people will come in, they'll have usually a swollen and red finger to start with, and that's very tender, almost more tender than you anticipate. And then over that time, they can get systemic signs, and then usually vesicles will pop up a day or two later. The vesicles are usually isolated and clear, and they merge and become more cloudy in appearance. So a lot of times we'll see again that red finger that's swollen, then a day later kind of see those clear vesicles, and then it becomes cloudy next day. Something to keep in mind. And then usually the pain is very large to the physical symptoms. So they can barely touch the finger, can barely move it. So anytime you see something like that, you want to think herpetic whitlow and get that treatment right away. So what other treatment for gladiatorium labialis and whitlow? So there's three main different antiviral medications you may use: acyclovir, famciclovir, or valacyclovir. Valacyclovir is Valtrex, acyclovir is Zovirax, and famciclovir is Famavir. For me, I mostly like to use the Valtrex or valacyclovir. The dosing is pretty straightforward, pretty easy to use, and it just makes a lot of sense to me. So that's what I mainly use, and that's what most people I would say do use as well. So for a primary infection, so no one's had it before, so first time they ever had it, you're gonna want to treat for 14 days. So I'll usually do 1,000 milligrams twice a day, and that's for the 14 days, and then we can go to prophylaxis if needed. If it's a recurrent infection, so they've had it before, and now they're having another outbreak, you only need to treat for 5 days. But again, it's 1,000 milligrams twice a day. So the treatment's the same, but it's how the duration of the treatment that matters for primary versus recurrent. For prophylaxis, so honestly, all of our wrestlers fall in the second group, which is less than 2 years of recent infection. So they're on a gram a day. A lot of times during season and tournaments, especially closer to Big Ten tournament and NCAA's, a lot of the wrestlers will go on prophylactic treatment just to make sure they don't get an outbreak during the competition, and they're usually on a gram a day. If they haven't had any outbreak in the last 2 years, they can go on 500 milligrams a day. But again, that's very rare for a lot of these wrestlers. And then for high school, if go back here for high school, if they have an outbreak for the primary, that's going to again be 14 days of treatment, and they cannot go back until 10 days of being out. Where in college, they can go back after 5 days of being out. For recurrent, it's the same for high school and college. They can go back after 5 days of being out on treatment. But again, for that primary in high school, they have to be out for 10 days of treatment before they can go back. So that's the only difference between the two there. Herpetic zoster is another one we see. It's not as commonly usually seen in the elderly, but we do also see it in the training room. So it's also known as shingles, and it's reactivation of the varicella zoster virus. Appears as a vascular eruption in a dermatomal pattern. So big thing is it doesn't cross the midline. You kind of see it go across the body and stop. And usually the people say dewdrops on a rose, and that's kind of the stereotypical appearance of that. Again, just like a herpetic gladiatorium, they'll usually have some hyperesthesia or some paresthesia or some pain in that area before the outbreak occurs. One time I saw a person who was complaining of rib pain in that, dermatomal pattern, didn't see anything on the skin. Next day they came in, had a full herpetic outbreak. So something to kind of keep in mind too, if they have that numbness or the burning pain, usually a sign or an indicator that they may have an outbreak soon, especially if they have one before in that same area. And for this, you can treat with valacyclovir or Valtrex 3 times a day for 7 days. As you want to start the treatment within 72 hours of symptoms and onset, because that'll give you the best chance of making the course less. So again, like we said before, skin lesions must have a firm adherent crust and no new lesions past 72 hours to go back to play. So for the NCAA, if they have no new lesions last 3 days and no, they're not oozing, everything looks okay, they can go back after 5 days of treatment. Again, if there's no fevers, no malaise, nothing like that, they can go back. High school, again, for primary, need to be treated for 10 days. They can go back again as long as everything is crusted over and no new lesions have been present the last 48 hours. Then for recurrent, it's 5 days, just like in college, where they can go back again as long as no new lesions are present last 48 hours and no active discharge. So the last virus we're going to talk about is going to be molluscum. So caused by the pox virus, you can have that flesh-colored papule, dome-shaped with a central umbilication. You're going to treat that with cryotherapy, curettage. You can also use KO8 solution, imiquimod, or cantharidin solution. Cantharidin is also the beetle juice, so that can be used as well. Return to play, college immediately, high school 24 hours after treatment. So as long as they get them removed or treated, they can go back in college right away, even the same day. But in high school, they got to wait 24 hours. Then verrucae or warts, usually caused by HPV, usually non-painful. However, on the bottom of the foot, they can be painful. So we can treat it usually with cryotherapy. You can also do curettage or K-weight solution, just like the other things we've seen in the past, Micomod and cantharidin solution. So if you want to use actual beetle juice, you can use cantharidin. It works pretty well. It just burns a lot. You can also, if you want to use a quick way or a cheap way, you can also use duct tape, putting duct tape right over it and leaving it on for 48 hours at least, if not for 4 or 5 days, and then pulling that out can essentially strangulate the virus and the HPV to allow that wart to die off if they're running out of things, or if the over-the-counter stuff isn't working, or if you don't have access to cryotherapy. Another one we can talk about real briefly is hand, foot, and mouth disease. I actually saw a lot of this in a few different teams, especially lacrosse, having outbreaks in the locker room. I don't know if people remember the monkeypox fear and the outbreaks that we were having too a couple years ago, but this was going around at the same time, so people are getting confused on the two. But for hand, foot, and mouth disease, usually caused by Coxsackie virus A16. However, it can also be caused by Coxsackie A6 or enterovirus 71. Usually can spread by respiratory droplets or contact, right? So if someone touches something, puts it in their hand in their mouth, they can contact it that way. You know, eyes, nose, ears, all that stuff can be very harbor that. So touching an infected person or a person's poop even. So people have done that, right? Especially kids, they'll touch someone's poop, another kid's poop, and then they'll put it on the block or whatever they use, touch their mouth, they get it, bring it home to the mom, bring it home to someone else, their brother, sister, they touch something, they get it that way too. But so it's very easily spread, can be contagious weeks after contracting the illness, even when they're better, as can stay in the poop for up to 5 weeks. So something they got to think about as well. So viral infections return to play. We already kind of hit on this. We'll just rehash this as well. So again, for primary herpes, for high school, 10 days of treatment, no new lesions for the past 48 hours. It all have to be scabbed, no discharge. For college, you know, 5 days of treatment, no new lesions for the past 72 hours, and no systemic signs for the past 72 hours, and no active lesions, and everything is crusted over. Recurrent, 5 days for both high school and college, and no active lesions as well. From molluscum, once it's treated, they can go back in college. High school, got to wait 24 hours after treatment. And warts, if it's in the face, covered with a mask. Non-face can be covered with like a Tegaderm. High school, face covered with a mask. Again, non-face, such as the arm or their trunk, covered with a Tegaderm and not permeable membrane. So now we'll get over to the sponge stuff, the bacterial infections. It's like your cellulitis, your folliculitis, your boils, MRSA, and impetigo, and hydradenitis suppurata, one word I can never say. So cellulitis, we'll see that in the skin. So it's infection of the deep dermis of the subcutaneous tissue. Can be form of staph or strep. When I see it, if I think like salmon pink, very quick spreading, I always want to think of strep. And then if it's dark meaty, like rare beef, that dark red purple, think of staph infections. Treatment wise, you can use beta-lactam antibiotics. These are your Cillins, like your penicillin, your amoxicillin, things like that. You can also use your cephalosporins like Keflex. So Augmentin, is penicillin plus clavulanic acid. So clavulanic acid is a beta-lactam inhibitor. A lot of these bacteria will secrete beta-lactamase to help kind of break down the antibiotic. So the clavulanic acid actually helps inhibit that from happening. So then the amoxicillin or penicillin can then actually go into the bacteria and kill that off. So Augmentin is another one that's very well used. And if isolated for beta hemolytic strep, we also want to use the beta-lactam antibiotics. And usually in the strep infections, we'll use those like Augmentin as a drug of choice. And then for staph infections, we'll think of more like doxycycline or Bactrim. Folliculitis, another one seen in people who wear knee pads, such as like volleyball players or with wrestlers. Usually pustule associated with a hair follicle infection. Usually Staph aureus, can be strep, but not as common. Can also be Pseudomonas. So football players or other sports that use the hot tubs, they may be increased risk of Pseudomonas. Can treat with topical clindamycin and mupirocin. Mupirocin is usually my go-to one for this, as it works very well with MRSA infections. If widespread, can use oral antibiotics. Again, Augmentin is a lot of times used. The thing we worry about is the Pseudomonas, what to use. This is a tricky one that has come up a few times because with these athletes, usually the treatment of choice for a Pseudomonas infection is those quinolones, like ciprofloxacin, and as we know, those carry a risk of tendon rupture. So it's not something we really want to give in our athletes. So you can Orally is really the only thing you can do for Pseudomonas is the quinolones, but you can do different things like like cefepime, if you want to do IM or other things like that, which we've done in the past for athletes who have Pseudomonas who do not want to give the quinolones to. We've done cefepime or other different cephalosporins you can do, usually IM to help with that infection. Again, usually if they're isolated folliculitis and clindamycin oral or ointment can be used as well to help with that. So boils and carbuncles. So these are your fun ones, your furuncles and carbuncles. So usually deep to the dermis of a hair follicle. These are the ones that usually need to get IND'd. Infection for the carbuncle is infection involving multiple follicles, so kind of similar to a furuncle, but more different follicles together. NOx are not needed unless you're worried about MRSA. So a lot of times just do an IND alone, help let it drain out, let the bacteria come out. Everything looks good. But if it is bigger or we worry about MRSA, you definitely do want to treat that with antibiotics as well. So here's a picture here of a furuncle and then a carbuncle. So you can see there you have that essentially boil with overlying cellulitis in that area too. That's something you will want to IND and get that bacteria out, let it drain. And then also you can decide if you want to do packing or not. So MRSA, these are going to be infections related to the insect bites. Can also be from locker rooms or secondary infections as well. Rapidly spreading, usually it's purulent. So anytime you see purulent material, usually you want to think MRSA, especially in your athletes in the locker rooms. CPUS, things need to be IND, think MRSA right away. Usually, otherwise, if it's not responding to antibiotics within 48 hours, think about MRSA as well. They're having systemic signs, fevers, swollen lymph nodes, things like that. You also want to think of MRSA. Can treat with IND, again, if abscess is present, plus antibiotic, usually be oral. And if that's resistant to oral antibiotics, you may need IV antibiotics. Bactrim, Doxy, or Clinda are the oral ones of choice. Kind of depends on where you're at. Some have high resistance to MRSA, depending on what region you're at and where you're at. You know, even between our hospital system in College Park and our campus, which is about 45 minutes away at College Park, you know, the hospital system has a different resistance to Bactrim versus the campus itself has a high resistance to Clinda. So we kind of go back and forth on what it is that needs it best. And then another one we can talk about is impetigo. That's something that actually looks a lot like herpes. It can be mistaken for herpes, but you definitely want to treat this as well. Usually has a honey crusted lesion, kind of around the nose and mouth. However, I've seen it everywhere. Due to staph or strep, again, it can be misdiagnosed as a herpetic outbreak. Diagnosis is usually clinical and culture is not needed. So commonly, I'll use mupirocin for this or augmentin as well. Um, especially a limited area, mupirocin works great. If it's more widespread or not responding to the ointment of the mupirocin, think of using augmentin or even using something for MRSA coverage like Bactrim. So return to play for this is going to be 72 hours of antibiotic therapy, no new lesions in the past 48 hours, and then no draining lesions. And active infections may not be covered to allow for participation. What that means is if they have a large boil um, or a large abscess, they cannot just cover it with a Tegaderm. They'll need antibiotics for at least 72 hours and no new lesions for the last 48 hours. Again, consider MRSA. Always think of MRSA in your athletes. It's not one you do not want to miss. So think MRSA if new lesions are happening or if drainage continues after 48 hours of oral antibiotic therapy. Now we're gonna get into a couple of fun things here. So hyaridinatus supervata, again, word I cannot say. Blockage of sweat glands with secondary infection. Usually this is going to see in your axilla. It can also be anywhere you have sweat glands, erythematous nodules and drainage. Usually again, IND is treatment of choice. If it is recurrent, we will do surgical excision and return to play. Athletes disqualified if it's extensive or if you're having a lot of drainage right away. But if it's not draining, they're usually returned to play pretty quickly. But again, if it's open and draining, they're not allowed to go back. Conjunctivitis, pink eye, another one we see a lot in our athletes. Usually it's viral most of the time, you know, even though people will freak out and think they want antibiotic eye drops, most of the time it is viral. It can also be allergy as well. Treatment is based on the cause of it. So again, mostly it's viral, so just symptomatic treatment. If it is bacterial, different things you can do, like azithromycin, Cipro, or erythromycin, usually that ribbon, that band. I like azithromycin a lot because it come in drops. Drops are a lot easier, less messy than erythromycin. Kind of depends on what pharmacy has. That's why I usually tell the athlete if that pharmacy is out of it, let me know. We try something different and give them what they have. If it's allergy, antihistamine or anti-allergen over-the-counter medication for the eye drops may be used as well to help with that. It usually takes about 3 to 4 days to fully recover from that. Then return to play. It's 24 hours of treatment and no discharge. This is very contagious. If they're having active discharge, they're very contagious and it can spread from person to person. So if they're having active discharge, they're not allowed to return to play. And then once they're on 24 hours treatment, they can come back. And then we'll move over to infestations. So pediculosis and scabies. So I hope the song is stuck in everyone's head. It's stuck in mine for about 5 days after I saw this picture. So for everybody else, hope it does the same to you. So let's talk about pediculosis at first, also known as lice. Most commonly affects school-age children, 3 to 10 years old. However, again, locker rooms, everyone's together. I've seen outbreaks of this as well. Treatment, usually permethrin cream or lindane or methionine, along with formite decontamination. Return to play guidelines require 24 hours of restricted activity, followed by completion of treatment and re-examination for complete response to treatment. So they cannot have any eggs, anything else like that. Once they're treated for 24 hours, they may go back. Again, talk about hygiene, no hat sharing, no headband sharing, things like that, helmet sharing, whatever sport it may be, and really get rid of this because they can be hard to treat if they keep trying to get back and forth. And the last thing we're going to talk about is scabies. So this has also been seen time to time in the training room. Usually it's the Sarcoptes scabi mite. Occurs in the area of the finger webs, feet, wrists, elbows, back, buttocks, anywhere essentially when you're laying down sleeping that you can get bit. Usually comes in clusters, usually like an S-shaped track of the skin by rows of small pimple-like mosquito or insect bites. People can say breakfast, lunch, and dinner. Treatment includes permethrin again, or lindane cream, or ivermectin even, as well as the formite decontamination. They are hard to get rid of, so you do want to get aggressive with the treatment on that. Return to play guidelines require restriction of activity for 24 hours at completion of treatment. In addition to negative results for scabies, minerals, oil under microscopy. Honestly, it's more or less just once they're treated and you get rid of the source, whether it be bed sheets or whatever it is, they're usually allowed to return to play. So we're going to end now today on a fun case study that we had come in the training room, and then we'll open up for questions. So a case study here is a 21-year-old male who presents with redness and swelling of his left hand. He was actually shark fishing here in Maryland in Ocean City the past week and woke up the next day with a swollen and painful hand. He was seen by a provider and given Bactrim yesterday and notes the redness is improved. However, his pain is not improved. He denies any fevers or chills, mainly just complains of moving his thumb, moving his hand, and states it hurts to do anything with that. And this is a person who has a high pain tolerance. He's a little odd kid, but his pain tolerance is really high. So when he says he has pain, we take him seriously. So the next day, the patient had an IND with mineral purulent material was expressed. So now we added augmentin to the Bactrim to see if that would help. Followed up the next day after the IND and noted worsening redness and worsening pain. So the picture here is a day after his IND. He also developed streaking. So it's hard to see, but in the picture on the right, there is some light red streaking going up the arm. He was sent to the ambulatory center for IV antibiotics. He was switched to doxycycline as well from Bactrim. Again, that switch from doxycycline was due to MRSA having less resistance to the doxycycline than Bactrim at the campus. He then continued the doxycycline for 14 days and had 3 days of IV ceftriaxone. He then continued to improve. And then his diagnosis actually was Vibrio. So here at Maryland, we have a lot of backwash, which is the freshwater and saltwater mixing together. And that area over by Ocean City is one of the highest populations of Vibrio. So he had a cut in his hand when he was shark fishing, put his hand in the water. We suspect that's where he got the Vibrio infection from. Most people get Vibrio by eating raw or undercooked shellfish. You can also get it from open wounds like coastal waters like we have here in Maryland. The CDC estimates about 80,000 cases of Vibrio happens each year, and then 52,000 result of getting in contact with coastal waters. Again, treatment usually is doxy and a third generation cephalosporin like we use with the ceftriaxone. Again, Bactrim does not have great use for Vibrio, so the doxy was a great choice in switching him over. So we'll go ahead and finish with the conclusion. Again, herpes. That's one thing I want to get you guys to know. Herpes, herpes, herpes. It's everywhere. Herpes infections are becoming more common, even in high school population. So people who just work with high school athletes still think of that as well. Recognition and early treatment is key, especially getting it within a day or two can minimize the spread and the outbreak. Tinea capitis is one of the tinnias that requires oral, just like tinea barbae, versus corporus, you can just use the ointments. INDs do not require antibiotics unless you respected MRSA. And then skin forms for NCAA in high school are very simple, and you can use them to use your guide to return to play. If you forget everything about this lecture, know you have that skin form to use that as a guide to get back to sport. So here's my references, and I guess we'll open time for questions.
All right. Thanks very much, Dr. Yost. That was awesome. For fellows on the Zoom or anyone sitting for boards, Dr. Yost's tables for the return to play and the treatments are incredibly helpful resources and definitely got me a lot of questions correct on the board exam. So I appreciate that. If there are any questions, anyone wants to come off mute to ask them, feel free. Um, Otherwise, I guess, Dr. Yost, just one thought that I have is, it's always hard having these return to play discussions with coaches and athletes when they're physically very well, right? And some of these skin rashes are really persistent and difficult. And, it's tough in the middle of a season to keep some of these athletes down for 5 days on some of these treatments, right? So talk about your experience with that and how you kind of navigate those sorts of conversations with athletes and especially coaches and any other stakeholders in that game. And kind of what you've experienced across the board. I know obviously a lot of coaches have wrestling careers and know that this is kind of part of the whole thing that comes with being a wrestler. But I'd love to hear your thoughts about and experiences there.
Yeah, I mean, that's a great question. And, with wrestling culture, it's kind of ingrained already. So a lot of coaches already know this and know it's part of the course. Not to say they're not going to argue with you or try to fight you on it and allow the person to wrestle, especially the time of year, right? If we're beginning the season now for wrestling, someone's out for one meet, they don't really care too much. But we're Big Tens and they can't get NCAA bid because they can't wrestle in Big Tens, they're going to try to argue you with it, right? The good thing about this is everyone's ever done skin checks before. So in high school or in college, how they do it, the athletic trainer will actually do the skin checks. And then, so say we're wrestling Penn State, our athletic trainer will look at Penn State, Penn State's athletic trainer will look at our team, and then the doc will be the final vote there. So if they see anything flagged, then, you can look at that and say yes or no, and let them go back or not. So the doctor will have the final say in that as well. High school, it's more or less athletic trainers will look at it, and then the refs will have the final say. But a lot of times, if you're there, the ref will just ask you what you think and what you want to do. I've had times where I've had to hold someone out at a state tournament because they didn't have the prior documentation. It's just the rules, and it is what it is. But there are going to be people who get upset with you. But just kind of letting them know, especially for these wrestlers, or if they have anything to pop up, let your athletic trainer know right away that hey, something's come up, so you can get that skin form. Because if you have that skin form, and so that the athletic trainer sees your whatever you have, say you have tinea corporis, right, and you see it on the arm. Oh, I got a skin form. I've been on treatment for 4 days now. Okay, you're good, right? So just making the athletes know, letting the athletic trainers know. That's me and my athletic trainer at Maryland. We always go over every skin forms, what needs to get filled out before they go into the tournament, just so they have it prepared, just to cover them and make sure everything is going on. But again, you're right. If it is a tournament, say it is herpes, there's nothing you can do about it. Just say, hey, I'm sorry. The rules are the rules. You don't want everybody else in your team getting it. So you got to do what you got to do.
Yeah, that's awesome. I think, wrestlers have their unique population and they see a lot of these unique skin pathologies and the rules are unique for them as well. So awesome. Any other questions from anybody? If not, we can give you about 20 minutes free back from your night. And thank you all for coming. Um, Dr. Yost is available via email if there are any questions that come up.
Hey guys, it's JP with Maryland. No questions. I just want to say this was a really informative lecture and was awesome. So thank you, both of you for it.
I got that on recording, Dr. Perlman. So
We'll hold you to it.
all right. Well, thanks everyone. Enjoy the rest of your night. And thanks again to Dr. Yost for taking the time to speak with us tonight.
Thank you, guys. Take care.